We're live.
Good afternoon. It's Tuesday, May 5th, 2 o'clock. We are going to start taking testimony today on S-278, which is an act relating to cannabis. And our first witness is Shayla Livingston. Hi.
Hi, how are you guys? Thanks for having me. I'm Shayla Livingston. I am the interim deputy commissioner for the health department, normally just the chief of staff. And I did bring a coat, but I can't put it on because I'm still too warm from walking up the hill. So
Very hot
sorry.
in here. No, we are always roasting. You're welcome to that.
And then online is Tony Folland. He's the on our clinical team in the division of substance use. And so he's our subject matter expert for the questions that I can't answer, which I'm sure may come up. So I didn't know what exactly you all wanted. I prepared a couple things that I can just walk through in terms of the differences between the House and the Senate bills, but I'm happy to take direction from you.
Sure. Yeah, you might as well start with what you've got.
Okay. All right. So from a public health perspective, just broadly, not about the bill specifically, but broadly, the most important things for us when talking about the different things that have been discussed in these bills this year, maintaining the existing THC potency caps, concentration limits, and single serving package limits to reduce the potential for overuse, dependence, and emergency care are really important. And again, I'll get into like what's in which bill, but those are important to us at the health department. Maintaining existing purchase and possession limits to discourage heavier consumption and diversion to underage peers is also important to us. And then maintaining advertising rules to decrease the chance that young people see and are influenced by this product marketing is very important to us. We have a lot of research around marketing and targeting and what how important it is to keep products out of sight from youth in terms of the marketing. So I'm going to dive a little bit into the details of the bills. The current version of the bill as passed by the Senate, bear with me here, does not raise the THC potency caps or the concentration limits, and it does not modify the advertising rules. So we are very happy with that. However, the current version of the Senate bill does increase the single serving package size and purchase and possession limits, which we would love to leave alone. Those are my main points. I don't want to keep talking. I could talk about cannabis and Tony and I could discuss lots of data and information, but those are my important points. So I don't know if you guys have questions about that or.
Yeah, I have a question for you.
Yeah.
If you're saying that if we increase the amount that's in each package, that it's more of a risk for younger people, are you finding that younger people are getting these products
Yeah.
from legal places where they buy them legally?
So the only way I can answer that directly is with poisoning data. So we know poisoning data, like our calls to the New England Poison Center, which we fund as like part of a New England group. Those have gone up for cannabis use. And so I'm going to be really clear. Often it's very unintentional. Somebody has the product in their house and a kid gets their hands on it.
Yeah.
Happens a lot to pets too. We're a little less worried about the pets at the health department, more worried about the kids, but so if a kid consumes that, the bigger the amount, the worse the outcome for that kiddo. And that, they're the kids that end up in the EDs or urgent care settings. And we have seen an increase in the calls to the poisoning center for that type of problem since the regulated market came online.
And do you keep track of visits to emergency departments?
Yes.
That are based in Vermont or all around?
In Vermont.
In Vermont.
So ED visit data we have, and we can show you as well. Tony, I don't know if you have those numbers off the top of your head. I can look at my computer, grab my computer and look that up for you. But we can send you the data on emergency department visits, poisoning calls, and then just use, when we see basically the dose is the poison, right? That's for anything in public health. And so when you see higher concentration limits or higher quantities,
Yeah.
that does, can be more serious in terms of the outcomes for how frequently they end up wanting to use, their risk for dependence, all of the pieces that
Mhm.
sort of end up in problem cannabis use that we don't want to see down the line. Tony, did I mess any of that up?
Without having the chart, what do the numbers look like? When you say they've increased, what does that mean?
Let me just pick up my computer.
That's what
I am
teachers-
trying to pull those up as we speak, folks. We have it all online, so I'm trying to pull that up so I can give you numbers. But broad swath, no, Shayla, you hit it exactly.
Yeah, Tony is going to be faster than me there, but we will get that. So hold that question.
I'll stand by.
Brett Bensman?
What is the size that we're talking about? I'm trying to find it in the bill.
So I believe we are not
The
raising.
packaging
potency.
size. No,
The packaging size.
Section 4,
It's 10,
page 3.
it's 10 items of 5 milligrams each is currently allowed. And I believe the bill increases it to 20.
No, it's 5 currently, and they want to increase to 10 grams for hash and 1 ounce, 2 ounce. Is that what we're talking about? For those limits?
Well, the bill does two things. We increased it, as passed by the Senate, it looks to increase the packaging limit from 100 milligrams to 200 milligrams.
Mhm.
And then also how much a person can possess,
Correct.
from 1 ounce to 2 ounces.
Right.
So it's section 1 and section 3,
The four.
3 and 4. And so it would be from 1 ounce to 2 ounce of cannabis, and then from 5 to 10 grams of hash, yeah.
Similar to a radish. Yeah. Okay,
No, it shall not contain more than 200 milligrams of THC.
right. So we already have a limit of 5 milligrams.
Okay.
Like for an edible, say, and you're allowed to have up to 10 in a package. And this would say you could have 20.
Oh, right here.
And we,
2 ounce, 1 ounce to 2 ounce, and 5 grams to 10
Yeah,
grams.
Shayla has the answer for it.
no, not an answer, just the packaging is important. So like Cannabis Control Board and the folks are doing a good job with the packaging. And that's like part of the deal here is trying to maintain, when if a kid gets into 1 pack of something, they can only get 1 smaller serving, and that packaging is harder to get into. And so like, the more they can get into and breaking into 1, the worse off we are. I will say I'm focusing on kids. It's also an issue for adults. If I served you guys birthday brownies, right? Not cannabis brownies, just regular old birthday brownies. And I give you a brownie this size, you might just eat it, even though you really only wanted 1/2 the size. And so that is just a human nature thing, right? Like that's like, oh, here's your serving of whatever, right? I don't know, it's an old movie, but if you saw like Super Size Me, right? Like this is a problem that is not specific to cannabis. It is simply a issue that we have. It's humans.
I have of this data, I certainly don't think we need it right this second.
Okay.
It's fine, don't
We
worry.
have it.
I know that you have it, and I actually have another data question for you that maybe if you can email us or share it with us later. I'm wondering about comparisons between states that do have either a higher potency, like milligrams per package limit, and their corresponding like visits, calls to poison control, visits to the ED, and like their helpline, the addiction helpline things. I like to compare things.
Yeah.
That would be interesting to see, I think.
That's a really good question. So I will say that we are a little unique, which I think is really positive. So I'm not make a bad thing. And that we do have the potency, we do have some different caps than other states. So it might be a little tricky.
Yeah.
What I can tell you is there is a lot of comparisons between states with regulated markets and states that don't have regulated markets and use rates. And the states that do have regulated markets have seen increases at different rates of youth use. However, I think it might be, I will look for that. I think it might be a little hard to answer that, but it's a great,
Yeah.
I love that question. I just don't know that the environment exists to make that comparison.
Yeah. That's the hard thing about all this
Yeah, but I can list.
cannabis stuff. And then my other, I just had another question for you. And it's gone, but I'll think of it. Does someone else have any questions? Now I'm gonna have to think of mine. Oh, I know what it was. Do we, does the Department of Health have education efforts, and outreach for adults who are legally purchasing cannabis about how to store it?
Yeah. Yeah, we do. So we have safe storage campaigns. We have how to talk to your kids campaign. So we have a lot of different public health campaigns about how to store it, going slowly, overuse, what that looks like, kids and how to talk with not little kids, like how to talk to teenagers. We do a lot of prevention work in communities through our coalitions and our prevention consultants and in schools. And that a lot of that is funded by actually the tax that goes into the Substance Misuse Prevention Fund. So yes, absolutely. We have a number of campaigns that I could pull those together too and send them to you to work on that with Vermonters.
And sorry, this isn't always my wheelhouse cannabis stuff, but now I have a lot of questions. Do you work with, are you the ones who put out that, what is it called, the risk assessment
Yes, the
survey?
risk behavior survey.
Yeah, is that, so that comes from you?
That comes from the health.
Okay, good. And that must inform the
Yep.
data you get about cannabis and
Yep.
okay.
So one thing that I think is really important from that survey, so for those who are less familiar with it, it's a national survey run by the CDC, but administered by states. And in Vermont, it's very cool. We actually go to all schools. You only have to do a sample of schools, but in Vermont, we do every school and survey every student. And so that way we can give schools their own data and supervisory unions their own data. And we have the state level and county level reports. In that, we ask a lot of different questions about cannabis use and many different substances and behaviors. And one of the things that we've seen is among the youth who use over the last few years, they're using it more frequently. And so that is not a good trend. So our increase in youth use, there has been an increase. It has been not huge, but still there, still not ideal. But even more concerning than the increase of the percent of kids who use every 30 days, within 30 days is the amount that they're using is increasing. So the frequency with which they are using cannabis is increasing.
And that's directly tied probably to how much, to just easier access to it, probably.
Maybe, we don't know. I can't tell you the cost from that survey.
Yeah.
That's
It's just a survey about the use. Thank you. Did anyone else have more questions?
How does the prevention program then intensify with what you've just told us?
Yeah. How do they target
Yeah,
different issues?
yeah.
So absolutely. So there is actually just a needs assessment that was done for the state for substance use prevention. So not just cannabis, all
Right.
substances. It's a requirement of a federal grant, but it's great that we have to do it because it's not just for that federal money, it's for all of our work. And right now, the way that we organize prevention work in the state through the health department is through regional, call them prevention lead organizations. They're just regional organizations that have a region and they narrow in on what's the problem in their community, where are the gaps in their community, what are the trends and the issues that they're seeing among their youth or their adults. And then they target evidence-based or evidence-informed interventions using that prevention dollar fund that we have here in Vermont to try to address those specific gaps, needs, trends, changes, because it is, even in Vermont, even in a small state, it is, you know, something that's different community to community. So it's very exciting because we haven't had that type of systemic long-term investment in prevention where we know the dollars are going to keep coming so that we can do this over the long term with communities and really support the work, because unfortunately prevention work does not bear fruit overnight, right? It takes a long time to have it down on the ground and have it take effect. And so yeah, so it depends is the answer. It depends on the community, it depends on the gaps. But there is some really, really cool and exciting work happening in our Vermont communities right now. And I think it's really great that we're able to do some more regionalized community-led work.
Family support is there in the family spectrum. I'm thinking really about young people, not yet 18 years of age. Where a child is struggling or is using this stuff, parent doesn't have strength enough or doesn't want to be embarrassed by the fact that maybe they don't like this whole idea of there being this substance in the community, but more importantly within the family. And seeing this child go through this, is there support for families around this?
So I'll
And
start.
education for
Yeah.
adults.
I mean, so I'll start with the Let's Talk Cannabis campaign, which we run, which is it's targeted at parents and adults and how to talk to kids about use. That's pretty big, right? That's broad, like that's a population-wide intervention. There's school-based intervention. So we have student like support specialists in schools that we fund who can sort of do more direct service type work with students. Of course, they have to either self-identify at school or be identified at school for that to work.
Yeah.
And then I'm going to turn to Tony for any other community-based treatment, Tony, that you know of or that I've missed.
From a treatment standpoint, a lot of what we're doing is really around kind of changing cognitive patterns, teaching people to be able to do kind of manage usually stress related pieces when it comes to without cannabis. So just to piggyback off what we were talking about before, the negative impacts that we're looking at. So to folks asking about the data systems, we've seen not only the calls to poison control go up. So pre-regulated market, there would be a call or two a year to poison control. Now we're talking in the mid-20s to mid-30s calls to poison control since the start of the regulated market of accidental ingestion for children. We've seen an increase for adults in those folks at emergency rooms. So somewhere around, again, we do things at the health department on, based on, 100,000 visits. We're increasing up to 11 of those are cannabis related, either primarily around cannabis or not, or secondarily related to cannabis. So we start looking at both the negative health impacts, so educating folks on the health impacts, and looking at the other pieces where I think the worry for kids, for me, beyond kind of the potential for addiction is that when we start drilling down on some of these data numbers, we look at kids who have like depression. So kids reporting depression in schools. Of those children who are reporting having depression, it is almost 50% of them are using cannabis. As where for kids reporting depression who don't use the numbers are much smaller. Kids who don't use cannabis are much smaller. For kids who are experiencing suicidal ideation, their use of cannabis is higher than it is for the kids who don't. So the dovetail between how these illnesses all impact each other and the sense of despondence that kids are experiencing and the management of their symptoms by using cannabis is really concerning for me. And how do we avoid giving more cannabis, putting kids in a position where there's more cannabis accessibility for them?
All right, I'm going to very quickly attempt to share my screen. Let's see if it works. All right. So, you asked about emergency department visits. So here's the emergency department visit data. So this is only to 2022. So we don't have the last 3 years, and that will get updated soon. But as you can see, like the ED visits for cannabis, and this is not for an age group, right? This is just all visits.
All
It's going up. Inpatient visits, I want to be really clear, it's very low. But we're not seeing a big increase in that. This is, I'm not gonna know how to say this right, Tony, but for hyperemesis syndrome specifically, also seeing an increase and only again to 2022. So need to update those data, but this is the type of data that we monitor and report out on. That's just the emergency department data. Tony was telling you about, again, going back to that youth risk behavior survey data. I'm going to send an email to your committee assistant and chair that has links to like a bunch of different cannabis use data briefs and data resources that you can scroll through. And let us know, like, if you have follow-up questions from them. But, you know, we do have kind of volumes of this kind of information. I don't want to overwhelm you with it to make, you know, just to, because I could go on and on.
Brett Kaufman?
Yeah, I'm just looking at your site.
Yeah. Which one you got?
Marijuana use in Vermont, but it
Yeah.
only shows to 2021.
So there's
In this one, I'm trying to find the newer version.
the newer version. Yeah, we
Because
will.
it shows data to 2019 and 2021, but it doesn't.
I think I sent an email of this nature to another committee. And so I will find that and it will give you the like most updated stuff. Some of it we don't update every year, like that ED one, we haven't updated in a few years. Some of it we update every time it comes out. So the youth risk behavior survey comes out every 2 years, that we update every 2 years consistently. Or behavioral risk factor surveillance system data is the adult version of that. That's a phone survey of all Vermonter, or it's a survey of Vermonters, not of every Vermonter. And that we also update those data every year in a report that I can get you.
Yeah, because I'd like to compare from this report to the newer one.
Mhm.
Because right now it says we're among the high, you know, when this came out in 2021, that quoting from it, marijuana use among Vermonters is consistently among the highest in the country
Yes.
and is the highest for 12 to 17-year-olds and 18 to 25-year-olds.
So that has been true for a long.
Right, and I want to know
time.
if there's any,
Like,
but with
like
the legal
many, many, many
market now,
years.
is it, you know,
Did it change? Tony, do you know that off the top of your head? That's like, since I started working at the health department 15 years ago, that has been the case. We've been a leader in a bad way. And
We have been a leader in the bad way and continue to be a leader in the bad way.
Pincinel?
Has the age changed? Like, is it getting younger and younger? I mean, it's scary to think that 12-year-olds are habitual cannabis users. Is it like? 9 and
like
10
our, is the use going, is it going down? So we do a middle school survey. I don't know that data off the top of my head. I will look that up for you if that has increased.
I don't think the ages are decreasing as much as the discrepancy of those folks who are smoking more and more frequently. So we go from, 20% of youth now who do smoke reporting they smoke 20 times or more a month versus,
Yeah.
I smoke once, I've smoked once. The chronicity of their use is becoming more earlier.
Yeah. Here's the poison data really quickly. So like Tony said, going up. Here's the data that Tony mentioned before that I think is really important. It's who is using. Again, I want to be really clear. This is not causal data. This is association, right? But you can see that the cannabis use versus no cannabis use is very different when we're looking at some of these other risk factors. And then, these are the really highest users of cannabis. So they're using 20+ days a month. They're 6 times more likely to have attempted suicide in the past year than those who don't use, right? So like there are associations with some pretty serious outcomes that we see. And this is why we get.
I just want to make it clear though, as we're talking about this, it could be that people who are experiencing depression are using this are using a variety of substances to try to handle the situation. So it's not necessarily that using the
Not
cannabis
causal.
is.
This is not
yeah.
causal.
Yeah, I just wanted to make it clear as we were talking to the rest of the committee that it's not, that it's not like using cannabis causes young people to feel to have suicidal thoughts. They're just kind of. And
Understood the cause.
yeah, okay, I know, I was just kind of talking about it out loud. It's hard to know in these situations because like when I see the data about the calls to the poison control, I think that seems pretty serious, but then I think, oh, also people are probably more likely to call knowing that now that it's legal, they're not going to get in trouble as a parent or an adult for having this in their home if a child takes it. Like, you know what I mean? I just, it's hard to take this data on like a straight level when there are probably other
I
factors.
hear you.
influencing it.
I definitely want to underscore the youth risk behavior stuff because that is not causal. I do want to give you a quick causal study, which we do is different. It's a national study in just a second. I would say I disagree with you on the poison control one.
Yeah.
So not that people didn't used to make brownies and candy on their own, but not at this level, right? And so like kids are way less likely to chew on a like bud of weed that's sitting around a house than they are to like pick up a gummy bear, pick up a brownie, pick up a cookie, pick up a yummy looking thing. Looks just like the vitamins, whatever. And so I think that hopefully people feel comfortable calling poison control. People call poison control. It's anonymous, which is by design because it's pretty, people get into trouble in all sorts of different ways. So I think it is really reflective of the fact that there is product that is attractive to children in much higher quantities now. But I hear you, and I do think it is important that people feel comfortable to call poison control.
They should.
I have done it. I've called poison control for my children.
You're not parenting if your kid hasn't eaten something different. I was wondering, Tony, did you have testimony of your own? I know Chair Byron said you both had to stop at 2:30 and it is 2:30 right now. Did you have testimony or anything you wanted to say on your own, or are you two working together?
No, ma'am. I was just here to support Shayla.
Okay.
I did want to tell you, so there's many different studies on cannabis use and mental health outcomes. And again, I really appreciate you underscoring the causality versus association. There's a very recent study that just came out last month about 400,000 or so adolescents out of California. And it was a longitudinal study. So the youth risk behavior survey, right? We're asking you all the questions at once. So that's why when I say like we can't figure out what came first, right? We're not looking at the causation. We're just looking at was it associated. With longitudinal studies, we can see that means over like a long period of time, and we keep asking you the same questions. And so then we can sort of see what came first. And in that, they did see much higher risks of developing depressive disorders and anxiety disorders and other mental health disorders when those kids were users of cannabis and users of marijuana. So again, I want to be really clear, Vermont data is just association based, but when we look at the science that's coming out of other states that look at longitudinal, causality, we are seeing pretty good evidence that unfortunately there is a causal link between use of cannabis and fairly serious mental health problems that we are seeing a higher prevalence of in Vermont and in the nation among our youth, such as depression and anxiety. So it's not again, my message is the Vermont data are the Vermont data. It's what we do as a surveillance tool here in the state. But the science and the evidence that is developing out of the nation, when we do it academically or when we do these bigger longitudinal studies, is really solidifying to say, this is not good for kids. We do not want kids using it. It is not healthy. It has real consequences. The more they use, the more frequency with which they use, the worse it is. We don't want it. And so that's why we're asking for again, the Senate version for the most part is really good in from our perspective, but why we're asking for the change in the serving size and to keep it the same.
Thank you. I think we all agree we do not want the children to have it.
I know.
I know, and it's too bad. It's hard to hear that data that, from the California study. It's difficult.
Yeah, it's not great.
Are we going to do some of that? Are we going to do some of that work here in Vermont?
So that has to be like a big, I mean, those have to be funded and run out of academia and, national level institutions. We at the health department do not have the resources or capacity to run them. They're awesome. They're needed. We often rely on the federal government for, funding and supporting a lot of that work. I agree. UVM, I mean, there have been really cool studies that have come out of Vermont and UVM, but we also don't have that many people, so that does hamper us occasionally. We don't have
that many children. And I've seen a lot of them. I'm not inexperienced. I can look at Tony, and I know Tony knows the street as well as I do. And I have a lot of trouble with it. I have a lot of trouble with legalization. I have a lot of trouble with the societal change. I think parents should be held accountable for the care of their children. And we taught a soft line of talk on this subject. We need to be a little more forceful, in my personal opinion. Tony, I don't know whether you remember me or not.
I absolutely remember you, sir.
Thanks. I appreciate that.
Well, thank you.
Kayla, I appreciate you too. It was a great presentation. Thank you.
I'll send you follow-up links.
Wonderful. Thank you both
Thank you.
so much. Appreciate it. All right,
Thank you
next.
for having us.
Thank you. Next is Amy Turncliffe, who's the founder and president of Rockford Scientific Consulting on Zoom. Hi, Amy.
Hi, thanks for having me. Can you all hear me okay?
Yeah, could you identify yourself for the record, please? And then you can go
Yes,
right
yep.
ahead.
Yep, I am Amy Turncliffe. I wanted to give you just a little background about how I'm qualified to speak to you all today. I have a PhD in neurobiology, and I did postdoctoral training with Bertha Madras at Harvard Medical School. And then over the past 20 years, I've been a consultant in mental health and substance use disorders. Over the past 10 years, I've used my expertise really focused on prioritizing public health and cannabis policy. So I live in Massachusetts. I've spoken on the topic in New Hampshire, other states, and federally. So I really appreciate the opportunity to talk to you all. I always mention this, I am mom to 3 kids, and they are 19, 17, and 14. And I'm auntie to 2 nephews who are growing up in Vermont, which is an absolutely gorgeous state. They are 16 and 14. So we have a lot of teens in our family right now. All right, I wasn't sure about the kind of format of, today. I usually speak in very formal, hearing proceedings. So I just want to congratulate all of you for the collaboration with your Department of Health. And I mean, honestly, it's refreshing to see. So I really do appreciate that. I wanted to because I'm a neuroscientist, I usually ground everything in science and do a quick kind of level set on cannabis. And I'm sure you're all well versed, so I'll try to skip through what I was going to cover. And then I was asked to speak about just cannabis events and kind of the public health concerns. And if you decide to move forward with cannabis public events or private events, and of what might be some outcome measures that you might want to take a look at to ensure you're tracking, what might be happening or not. So this is kind of piggybacks on the conversation you were just having around a single serving size and whether or not that should be increased. In Massachusetts, we have a serving size of 5 milligrams. I know some other states have 10 milligrams as their serving size. But I think it is important that in May of 2021, the National Institute on Drug Abuse defined a single dose unit as 5 milligrams of THC. So that's kind of the federal kind of for research purposes dose unit. And then that's essentially about equivalent to 1 serving of alcohol. So 5 milligrams THC, 1 serving of alcohol, that's defined as a beer, that's 5% alcohol, or a 1 ounce serving of an 80 proof liquor. I mean, that's the standard alcohol. And then I think, I believe have a THC flower cap of 30% THC, back in 1990. I think I graduated high school in 91, so we'll just call it 1991. I'm dating myself. Standard kind of THC flower was about 3% THC. So now a joint or a pre-roll today is generally about 10 times more THC than a joint of the same size would have been in 1990. So a vape cart, I grabbed one off of a dispensary website from Vermont. That contains 86.5% THC. It's a 1 gram vape cartridge. It contains 865 milligrams of THC. So that's about equivalent to almost 1990 joints. And it's about equivalent to 173 servings of alcohol, or 173 5 milligram defined, right, NIDA defined THC dose units. And that's a little bit more than a keg if you're equating it to alcohol. So I think that's a single vape cart. So just so you know. And then 1 ounce of cannabis flower, that's 30% THC, is about 8,400 milligrams of THC. That's about 840 joints from 1990. And it's about 1,685 milligram NIDA defined THC dose units. It's approximately equal to 10 kegs of beer or 13 gallons of 80 proof hard alcohol. So just to give you an idea of, I rarely see it broken down in this way. So if you're thinking about increasing from 1 ounce to 2 ounces, you can double all of those numbers. I just think I think as a nation and society, we have to start kind of breaking it down so that can understand what that actually looks like in terms of dosing.
Yeah, it's interesting that you're comparing it to alcohol because you can buy a keg.
Yeah, you can.
You know what I mean? So
yeah, you can have it, but if people were to be walking out, I mean, I don't know how often people are buying like 20 kegs, right? So, so just something to think about, right? In that way.
Sure.
And which brings me to my next point, which is I don't usually equate it to alcohol. This is actually the first time I've ever equated it to alcohol in a presentation, actually. And the reason for that is what I'm going to talk about next, which is when someone consumes a cannabis product, right? The THC, if you consume it through an edible, it's absorbed fairly slowly, right, into the bloodstream. But if you inhale it, it's pretty rapid. So the THC enters the bloodstream. THC is lipophilic. And I don't know, maybe you know this already. I'm sorry if I'm repeating something you already know. But it's lipophilic, which means that it sticks to fats and lipids in the body. And so once it is absorbed into the bloodstream, it rapidly redistributes from the blood into fatty tissues. And the brain happens to be one of the most fatty tissues in the body, but also into fat cells, right, around the body. And then THC can be released slowly from fatty tissues, including the brain, for days, weeks, or months. This is why someone can fail a drug test like long after they've already consumed, right? The impairment from a 5 milligram dose that someone who doesn't use regularly takes lasts about 2 to more than 8 hours. It's highly variable because it's right. The THC is lipophilic and it stays in the body for a very long time and can be released over time. That's very different from alcohol. And alcohol is hydrophilic, and meaning it dissolves in water. And alcohol distributes throughout the brain and body in a relatively predictable way. So that's, we typically say it's metabolized and cleared relatively quickly and typically within hours. And we usually say, right, a drink an hour. If you do a drink an hour, you're probably okay to drive. And that's very different from THC because THC accumulates in the body. And if somebody uses regularly, and talking about the teens that are using more frequently, or even young adults that are of age, we know that there are, unfortunately, our highest percentage of them are using, then the THC accumulates. And it can actually take months and months after someone who uses regularly to stops using for that THC to clear the body. Okay. So to summarize, high THC content increases the potential for health and safety harm. THC is processed by the body very differently than alcohol. So that's why I don't usually use the comparison. THC is fat soluble and alcohol is water soluble, meaning that THC can accumulate in fatty tissues, especially the brain, and can be released over time, which increases the potential for delayed impairment and for prolonged impairment. And then cannabis in particular, THC can cause short and long-term impacts on physical, cognitive, and mental health, including cannabis-induced psychosis, which is actually my area of expertise, but I'm not talking about that today.
Right.
And then these impacts are especially relevant for adolescents. And I do want to point out that's now being recognized as up until age 32. There was just a recent study, a really impressive, elegant study that showed that adolescence extends to 32. And so that's because of the important role of the endocannabinoid system in brain development. And that's our natural endocannabinoid system that the THC interacts with. So I now just wanted to hopefully quickly move through the public health concerns with cannabis events. And the first is social normalization. And I think that your previous guests talked a little bit about this, which is that young people are influenced by what they see and hear in their family and in social circles and in their communities. So social cannabis events, especially public events in communities, are likely to reduce the perception of harm associated with cannabis. And then research has shown that more cannabis outlets in a community is associated with more youth use and more intention to use. And when I say more youth use, that could be more young people using and or more the people who are using use more frequently. And even if entry is restricted to adults 21 plus, social use venues can normalize cannabis use as something that's something to do for fun, and it's especially when it's located near areas where there might be adolescents hanging out. And then, so essentially the concern is not only direct underage entry, which also is a concern, but also increased visibility, adult to youth diversion, and then just exposure to higher THC products and reduced perception of risk. The second public health concern is overconsumption. And, this is obviously a concern regardless of whether you're talking about social consumption or not. But typically when people are consuming in a social environment, there's some amount of kind of, I don't want to call it peer pressure, but a little bit. If people who aren't experienced consumers are consuming with people who are, they might feel like the need to consume more. So I mentioned that a NIDA defined dose unit is 5 milligrams, regardless of consumption methods. I mentioned that THC is fat soluble compared to alcohol, which is water soluble, which can make it highly variable, and the clearance of THC can be much slower. And then we have high THC content in today's products with like a half a gram joint, that's 30% THC, can deliver 150 milligrams of THC. The signs and symptoms of overconsumption can be cardiovascular, like palpitations and tachycardia, gastrointestinal. We mentioned cannabinoid hyperemesis syndrome, which would be abdominal pain, nausea, and vomiting. And then central nervous system, dizziness, sleepiness, lack of coordination, confusion, amnesia, anxiety and nervousness, paranoid reaction, delusions, hallucinations, depersonalization, dissociation. And I had a little thing about cannabis-induced psychosis and schizophrenia, but I won't. That's not for today. And then public health concern number 3, I think, is usually the largest that people think about, which is impaired driving, right? So not only does that impact the person who's driving, but also pedestrians, other drivers, police, EMS, and kind of the general local liability exposure. THC has many of the same impairment effects as alcohol, including slowed reaction time, foggy memory, impaired coordination, impaired attention and judgment. And then studies have actually found that even if a person feels like they're okay to drive after consuming THC, they still show impairments in key driving functions. So THC impairment can be delayed. It can be hard to self-detect, and then less predictable than alcohol. And in fact, the Colorado, I'm always blown away when I recite this, but the Colorado Department of Public Health and Environment says publicly, it's on their website, to wait at least 6 hours after smoking marijuana containing less than 35 milligrams before driving, biking, or performing other safety sensitive activities. And if you've smoked more than 35 milligrams, you need to wait longer. And I was just saying that like a pre-roll, that's a half a gram, can be 150 milligrams of THC. And then wait at least 8 hours after eating or drinking marijuana containing less than 18 milligrams THC before driving, biking, performing other safety sensitive activities. And if you've consumed more than 18 milligrams, wait longer. So even a standard 5 milligram dose unit, the Colorado Department of Public Health and Environment would say wait at least 8 hours before driving. Public health concern number 4 is secondhand smoke exposure. So if smoking or vaping is allowed, workers, patrons, nearby residents, people walking by the venue may be exposed to secondhand cannabis, either aerosol or smoke. And this is generally considered to be counterproductive to smoke-free workplace advancements. The CDC notes that secondhand cannabis smoke contains not only THC, but many of the same toxic and cancer-causing chemicals that are found in tobacco smoke, and in some cases at even higher amounts. And a study was just published that found high levels of toxic metals in vapor from THC vapes. So this raises concerns for employees, pregnant people, people with asthma or other respiratory diseases, and then neighboring businesses and housing. And then the 5th and final for today, public health concern, is a lack of compliance with public health protections. So I do certainly want to commend Vermont, because you all have honestly, in my opinion, been leading the way for public health protections, or one of the states along with Connecticut, leading the way for public health protections. So Vermont has enacted proactive policy measures to reduce cannabis-related public health and safety harm. But as kind of we've heard, even with the best of intentions, local officials may face practical enforcement issues in areas like preventing co-use with alcohol or other drugs, monitoring intoxication and impaired driving, preventing diversion to underage people, managing odor complaints, ensuring worker protections, and avoiding accumulation of impacts in communities that are already burdened. And then some of the public health related outcome measures that you may want to track or continue to track because it sounds, or track more closely. It sounds like some of these are being measured already in Vermont, which is great because you'll have a history and you can look forward. Would be collection of quantitative and qualitative data from your host municipalities, and would include the impact on utilization of local services, like first responder utilization, law enforcement, EMT services, tracking OUI cannabis, underage use, emergency response for both physical and mental health crises, and then local and state emergency medical services utilization, include medical emergencies that have a cannabis code. And I know that coding can be tricky. I would just encourage you to make sure that your physicians are using cannabis coding. And then if event attendees are allowed to leave the premises with product, as they will be in Massachusetts, which I don't think is a great move, consider assessing child poisoning data moving forward. And comparing it with where you're at, which may again fall under emergency medical service utilization or may just be poison control calls. And then compliance checks are a great way to see how things are going. So especially for public events where you can look at underage access, compliance with prohibition on alcohol co-service, and then any compliance with sales limits and permitted product types and things like that. And then the second in a bucket I had in terms of category was assessing your local and state adolescent health survey data, especially in and around communities that are hosting cannabis events. So this may help to show if changes in cannabis or THC product availability are happening, changes in perception of harm, changes in perceptions of disapproval that may be associated with seeing events publicly. And then you can also include or are asked to be included questions about whether teens or underage persons report seeing or attending a state licensed cannabis event. So that's all I had, unless anybody has any questions.
Thank you so much. Does anyone have any questions? Rep. Nugent?
As far as collecting that local data, have you seen municipalities do it? Or how would you go about it, do you think?
Yeah, so I haven't seen a great, it depends on what you're talking about. In terms of local, and I think it sounds like you have this too, local adolescent health survey data, that's usually, in Massachusetts, that's done in like a hodgepodge way. It sounds like you have a much more coordinated process for that. So hopefully that will be easier. In terms of collecting quantitative and qualitative data, I think that would be something you need to be asking communities for at the outset, because I don't see that local municipalities are doing a great job of collecting data. I don't even see that they're doing a great job with compliance checking, just generally, of their retail establishments. And maybe that's, I want to put it very kindly, maybe that's Massachusetts specific, because Massachusetts has had a lot of issues with our regulatory body, so and enforcement and communication maybe with local kind of municipal leaders. So I would just recommend that you do that from the start and have a very clear kind of a list of what you'd be asking of them.
Thank you. We really appreciate it.
Okay, thank you all.
Thank you. All right, next you Sheriff Mark Anderson on Zoom. Hello.
Good afternoon, Madam Chair.
How's it going?
It's going well. For the record, Mark Anderson, Windham County Sheriff. I am here on behalf of the Vermont Sheriff's Association. I'm the past president of the association, and I was the person that we can make available on short notice. So that's why I'm here today. Do you want me to just fire away? I don't have much testimony.
Sure.
Great. We have no awareness of this bill. The other body did not invite us in, so it was a bit of a surprise when I saw this. I do appreciate the House Committee on Government Operations and Military Affairs inviting us in for it. But we have no position because we didn't even know it was a topic. I understand that I'm being asked to speak to Section 5. So the primary factor here is whether or not it makes sense for law enforcement presence to be there. I'm going to make analogs to alcohol, and hearing the prior witness speak to why she doesn't make it. I totally understand all those things, but we do have systems, infrastructure, and logistics in place with alcohol, specifically through the Department of Liquor Control or Liquor and Lottery now. They have an enforcement branch, and so there are analogs, at least in structural systems. It is not uncommon for organized licensed events to have some form of a security plan, law enforcement presence. To have this specified by the Cannabis Control Board makes sense and is consistent, as far as I understand it, with what the Liquor Control Board does. The primary concerns from law enforcement are generally around impaired driving. While I don't believe this bill is to deal with impaired driving specifically, I have to use as an opportunity to make my honorable plug. One of the issues and areas that Vermont law enforcement has struggled is identifying funding for what we call a green lab. A green lab is a training tool that we use to train law enforcement officers on what a person who is impaired by cannabis, what they look like. We have what we call wet labs, which is where we have people who are dosed with alcohol in controlled settings, and then we can, in a training environment, show law enforcement officers how to recognize signs and symptoms of impairment with alcohol. Green labs are difficult because most of the funding related to alcohol enforcement is federal funding, and federal funding currently prohibits any purchase of marijuana, cannabis, or related products. So we struggle anytime it comes to how do we actually fund that program. Last legislative session, we were trying to see if we could secure an amount of money for from the opioid settlement funds to see if we could use that. It's not a significant amount of money in the grand scheme of the state budget, but it's not a small amount. I want to say it was in tens of thousands of dollars to procure all the things that go to operating a green lab. If the committee has any interest in hearing testimony on a green lab, John Flanagan, who is the state coordinator for the drug standardized field sobriety testing and all the things with impaired driving. John Flanagan, who's at the Vermont Police Academy, is a great person to ask for. That said, that's my honorable plug. As a sheriff, the only concern that I have in Section 5 is if I were asked to provide services for an event and I don't have people, then what? It seems that private security is an alternate option. So broadly speaking, with little prep time for this bill, I don't have any brilliant thoughts to share with you other than what I've said so far.
Great. Thank you, Sheriff. If you are interested in coming back after you've had some time to review it and discuss it with your colleagues, just let us know. That would be great. We can check back in with you too about that. And Rep. Coffin has a question.
Yeah,
Yes, sir.
thank you. Just if for future, if you could please come back. What happens when you pull someone over and you suspect them of being impaired, but they're obviously, you don't smell alcohol on them or anything, but say you smell cannabis in the vehicle, what are the procedures there, or can you even test on the road?
So a few things. We in Vermont, most law enforcement officers who perform patrol work will take the National Highway Traffic Safety Administration's standardized field sobriety testing course. So that is how we teach Vermont law enforcement how to recognize and detect an impaired driver. It's not, notice I did not mention alcohol. It's not an alcohol specific training, but it came out of the origins of alcohol. And so there's a secondary course, which the legislature back, I want to say about 15 years ago, as part of the legalization efforts, said all Vermont law enforcement needs to have what's known as ARIDE. That stands for the Advanced Roadside Impairment Detection Enforcement Training. We love our acronyms. That is an advanced level of training that we provide law enforcement officers after they have some experience recognizing impaired drivers to recognize at a greater degree and be able to direct how we collect further evidence on an impaired driver. There's a third level, which is known as a drug recognition expert. That was a program developed through both clinical and field tests and studies with the International Association of Chiefs of Police and National Highway Traffic Safety Administration, Johns Hopkins University, and many others that trains law enforcement officers on how to recognize what type of drug, what category of drug a person is impaired by. If they're impaired by one category, such as a cannabis product versus alcohol, we can actually differentiate where those impairment levels come from. And that is a result of some advanced training that roughly, I want to say we're at about 50 DRE trained officers in the state of Vermont. So the ARIDE feeds into the DRE program. DREs are funded through federal funds to help assist and offset the burden to the state budget in recognizing and reducing motor vehicle crashes related to impaired driving. I will also throw out one fun fact, which is, generally speaking, in Vermont, motor vehicle crashes are driven by three primary categories. One is speed, one is distracted driving, the third is impaired driving. So this is a significant concern when we talk about reducing motor vehicle crashes. AAA for years advertised the total impact of motor vehicle crashes on economies. We're talking over $1 billion lost related to motor vehicle crashes. Now, I'm not saying that's impaired driving related. I don't want to suggest that. But when 1/3 of the crashes in Vermont are impaired driving related, and we consider all of the impacts, whether it's the loss of a vehicle, loss of work time, loss of medical or medical expenses, all the things that tie to what happens from motor vehicle crashes, it's certainly one of the reasons why law enforcement cares so much about impaired driving. But I also will say, when people can be responsible and can do things in a well-regulated environment, like, that's a good thing. And that's why we have systems and institutions in place. So to that end, I think that there's ways that we can develop structures based on the policies the legislature comes up with. And I probably answered that question in about 500 sentences more than you needed.
Nope, I like.
Rep. Nugent?
I was just wondering if the tracking, like place of last drink, if that has become, or if you know if it's become more uniform across the state, if when people are found to have, be intoxicated or.
Thank you, Rep. Nugent. So place of last drink is collected when we submit a person who's been arrested for driving under the influence or suspicion of driving under the influence. When they are processed, we collect it in what's called the DMT. It's our evidentiary collection tool that's located at most law enforcement agencies. So that's where we generally capture the place of last drink. Department of Liquor and Lottery, and I would suggest Brandon King if you need to hear more about that. Department of Liquor and Lottery does a lot of work based on that. We also capture it in the statewide Valcor records management system. This is a tool that all or almost all law enforcement in Vermont uses. There are some agencies who opted to go a different path. So generally speaking, it is 95 to 98% available. If it's collected, the DMTs are a place where it is collected because it's prompted by the investigating officer. That will not impact cannabis as it stands right now. Software updates would need to be done. I believe it's the Department of Health who manages the DMT program.
Yeah, I guess that was, yeah, so is that happening for cannabis? I guess is my question. Yeah, so it sounds like.
Only, so it would have to be a voluntary identification in the Valcor records management system. The DMT is the wrong tool to collect the evidence. When we talk about collecting evidence for drug impairment, we're usually looking at a blood draw. Place of last drink, John Flanagan will actually be another person to talk about how it reflects on impaired driving other than alcohol. He collects a lot of data points and charts and graphs and pictures to point out what drug impairment in Vermont looks like on our highways.
All right, thank you so much. Thank you for coming in at the last minute.
My pleasure. Always great to see you, committee, and thank you for your time.
All right, yeah, let us know if you want to come back.
Yes, ma'am.
All right, and then finally, we have Jean Hamilton, who's the Director of Program Development from the Land Access and Opportunity Board. Hi, Jean. Nice to see you again.
Hi there. Thank you all. Yeah, thank you. We just got notice of this invitation. It sounds like many others just an hour or so ago. So I'm sorry that I am not there in person, but appreciative of the invitation. I'll start with an introduction. My name is Jean Hamilton, and as you just said, I am one of the co-directors of the Land Access and Opportunity Board. And yeah, just appreciate you inviting us in to testify on the bill. I will also say, since we just got notice, I am actually not sure what the current version I don't know that I'm up to date with your most current version of the policy language. And so I'm going to do my best here, and hopefully if there is an opportunity this year or in the summer to keep working with you all on aligning along the CCB's priorities of supporting initiatives like the LAOB.
Yeah, we're working on the version that was passed out of the Senate.
Great. Okay. Thank you.
Exactly what I was going to say.
I'm sorry, what was that?
Oh, no, I'm sorry. That was a little banter between Reps Waters and others. Yes. So
Yeah, go ahead. Thank you. Yeah, it's the same version. So we're just starting to take testimony on it now.
Oh, got it. Okay, you're just starting now. Okay, got it.
Yeah.
Thank you. Okay, so the Land Access and Opportunity Board was created to improve access to woodlands, farmland, and land and home ownership for Vermonters from historically marginalized or disadvantaged communities who continue to face barriers to land and home ownership. This is challenging and complex work. And as we enter into our testimony today with you, I want to start, as we so often do, by sharing our touchstones and inviting you to hold these touchstones during our time together today. So LAOB's touchstones are to listen generously, to speak your truth from your heart and mind, to make the way we work together an example of what is possible, and to trust that we all hold a piece of the puzzle and that we need each other's pieces to understand the whole picture. I know we've been in with your committee before, so I will not say too much about the LAOB, but I do want to say this. The LAOB was created to help the state of Vermont understand and remove the barriers that disadvantaged communities face in achieving land and home ownership. Our communities face barriers that are the compounding result of generations of unjust and discriminatory laws and practices. And the reason we're here today is because one of those sets of laws and practices is the war on drugs and the discriminatory nature of how cannabis has previously been criminalized and the impacts, the long-lasting intergenerational impacts of that criminalization on our Vermont communities today. So discriminatory policing of cannabis has undermined our community's economic stability, and economic instability causes housing instability with damaging impacts for all of us. The Vermont Department of Health found in its 2024 state health assessment that, quote, lack of affordable, safe, and accessible housing leads to housing insecurity, mental health deterioration, and financial strain. Key housing issues include substandard housing environments due to neglected maintenance, the high cost of housing, a limited number of contractors available to make repairs, landlords raising rents while not maintaining properties, and economic support policies and initiatives for affordable housing that are not addressing acute needs. Housing discrimination further limits access for many marginalized communities. It's interesting that we have this relationship between housing and the Department of Health, and this conversation that we've heard today from the prevention team about the corollaries and a question of correlizing and causation between substance use, cannabis use, and deteriorated mental health functions. Something that I really want the committee to think about as we're thinking about, is this causal, is it correlative, is to incorporate into the vision, how does housing instability, how does homelessness or losing homes, being evicted, not having economic opportunities that are obvious to you in your community, how do those factors cause and correlate with declined mental health and potential substance use disorders. Housing is an incredibly important factor when we think about what are the most important ways that we prevent substance use disorder. Since its creation, the Cannabis Control Board has recognized the, quote, disproportionate impact of the historically government-led policies that fueled the economic oppression of Black and Brown people for generations and continues to disadvantage these individuals as well as Indigenous people, people of color, and other historically marginalized groups. The board, in this case, the board is the CCB, aspires to build an equitable and accessible program in order to mitigate the past harm inflicted by the prohibition of cannabis. The CCB in its 2024 Act 166 report also found that, quote, given the inherent barriers to accessing the industry and the ongoing challenges to achieving sustainable success, the CCB and the Cannabis Advisory Committee concluded that the social equity program alone is inadequate to mitigate the harm caused by historic drug policies and has called for the creation of a community reinvestment fund in many prior legislative reports. And in that report, it recommended dedicating 25% of the cannabis excise tax to the Land Access and Opportunity Board for community reinvestment. So when S278 passed out of Senate Economic Development Committee, it contained an appropriation for the LAOB, and we support the CCB Act 56 report finding that led to this inclusion in their version. And that finding is, quote, from a public health and prevention lens, directing cannabis excise tax revenues to provide grants and technical assistance for affordable housing, land access, and community-led development would help address upstream determinants of health, stabilizing families, reducing stress and insecurity, and creating safer, more resilient neighborhoods. We at the LAOB have done the groundwork and are able to deploy funds into programs and projects that have been vetted and developed by our communities in collaboration with state agencies and service providers to heal the very real harms of housing and economic insecurity experienced by our communities who have been negatively and disproportionately impacted by discriminatory cannabis criminalization. We at the LAOB are interested and ready to work actively with you all, with this committee, more broadly with the whole legislature, with the CCB, with the Department of Health, and any other parties that are willing and ready to work with us to ensure that the cannabis market we have here and that we continue to build addresses our community's core needs for stable housing, land access, and opportunity. Again, I'm going to say it again and again, housing, access to land, access to economic opportunity are core structural drivers of both public health and thriving community economies. And in the bill that passed out of the Senate that you all are working on, some specific recommendations that we see as opportunities are really interesting to see what's coming out of the federal government right now. And so in Section 27, as we are facing the potential of interstate commerce around cannabis, it is more important than ever that we ensure that we work to protect Vermont's interests related to our marketplace. We are supportive of the provision included in that Section 27 that says an agreement shall include appropriate provisions reflecting board programs and efforts to promote the inclusion and support of individuals and communities in the cannabis industry who are linked to populations and neighborhoods that were negatively or disproportionately impacted by cannabis criminalization. We also support the expansion of that beyond the cannabis marketplace, because as we've heard and learned from the CCB before, many more community members have been negatively impacted by the prior criminalization of cannabis than are able to or want to participate in the cannabis marketplace. So these equity investments really can and should extend out beyond just the cannabis marketplace. And this is an opportunity to take an excise tax from cannabis and invest in the stabilization and security of all of our Vermont communities' housing needs. We also, at this point, when we're looking at interstate commerce and a growing cannabis market, really need to think about expungement. And are we doing enough? How can we improve our expungement program so that we are serving folks who no longer live in Vermont, but were impacted by Vermont's criminalization of cannabis? And another aspect I think your committee probably has eyes on, and I hope you will have eyes on, is that as we face the very real possibility that our cannabis marketplace will shift into an interstate marketplace, that Vermont will be entering into the challenging circumstances that we face in so many of our marketplaces, like food and agriculture, and manufacturing. That Vermont does not have the same kind of access to economies of scales that other states have. And our cannabis marketplace, because it is so highly regulated, is really at risk. There's a lot of challenge for small scale producers, and we are very much at risk by being kind of consolidated into the businesses that have a high level of capitalization and are large businesses that do have those economies of scale. What Vermont has proven again and again is that when we compete on our excellent brand values. We compete well when we create marketplaces that are based on craft production, local, businesses that have direct relationships with their consumers. And unless we do this to support our cannabis market, we will see a cannabis marketplace that spins out in a direction that does not support these core kind of selling points, what brings extra value to Vermont and Vermont businesses when we cannot compete on those economies of scale. And so especially as we face the potential for planning for interstate commerce, it's really exciting to see that there are still direct sales provisions in here. And in this bill, we encourage that continues because of the value that direct sales channels create for small scale producers and small businesses. And moving forward, it has been really interesting for me and also for LAOB to work on cannabis policy over the last couple of years. We see some exciting opportunities with this bill. And again, we are grateful that your committee is taking it up and giving us an opportunity to speak on it. Moving forward, we would like to continue working with you. And we really encourage you to address these issues. This bill really deserves to have some appropriations tied to it, and specifically to make investments into the Cannabis Business Development Fund. This is a marketplace that businesses need a lot of help to navigate. This is a complicated, capital-intensive business that does not have any of the typical support structures of the Small Business Association or Farm to Plate or any of those other places where we typically support our small businesses. The Cannabis Business Development Fund is really important. If we are expanding the fund availability to more producers, but not putting more money into the fund, that is going to create a problem. So expanding appropriations there, really thinking strategically about how do cannabis excise taxes, how can we use these taxes to address the critical needs our communities have around housing, and developing civic capacity at the community level so that communities can lead on the problems that they are facing. Working together again to really strengthen and deepen the opportunities for craft producers and developing and strengthening Vermont's identity as a craft cannabis marketplace. And then one of our biggest disappointments this year with this cannabis legislation is that once again, we have a year that there is no meaningful cannabis legislation addressing the needs of medical marijuana patients and providers. And so really encouraging this committee and all of you as legislators and lawmakers to connect with the medical community and hear about the needs from patients and make sure that we are not continuing to fall behind on addressing those needs. So thank you for inviting us in, and I hope this was okay, how this landed. I didn't know exactly what you were hoping to hear testimony on, but I'm very open to hearing any questions, feedback, or redirection if you were hoping I was going to speak on something else today.
That's really helpful. Thank you. And thank you for being amenable to coming in at the last minute to talk about it. Did anyone have any questions? All right.
Just a little bit more
Chair Byron.
commentary, just a little bit more commentary as I came in late from being up in House Ag on the hemp language. Yeah, apologies for like loose communication with you. We were late taking this bill up for any witness testimony. So this was really what you gave us is what we were looking for. We're just looking for a table set of where your head was at with your organization for the bill as passed by Senate. And now that we've cleared our deck of a couple of other big things that we had to get out of the way, we're really like pedal down on this one. So would like to have you come back once we start getting like a little bit deeper into the sections, but we really just wanted to get your perspective on the words as sent over by us.
Okay, great. Thank you so much. And yeah, I have to admit that my mind has started to shift into the like, what can we do after session? Because is anything else still happening? It's exciting to hear you're working on this bill, and I will shift my brain back into what could we work on together this year, and follow up with you, Chair Byron, if that's okay.
No, that's wonderful. And yeah, no, so we are really just starting to take our first look at testimony hearing from stakeholders about what was sent over from the Senate so we can decide how and what we're going to do with the words in front of us now.
Great.
Cool. And it's good to see you.
Nice to see you all. Thank you.
All right. Any other questions for our guest committee?
No?
All right, cool. And with that, I guess that is our final order of business for the day, correct?
Yeah, that was it.
Do you want to take us off?